So pregnancy as such is a physiological state, but during pregnancy, lot of things happen which makes it pathological. And one of the problems in pregnancy, which is not very common, but we do see such cases, and we should know how to manage it. And one of such situation is chickenpox in pregnancy, because pregnancy is an immunocompromised state. So pregnant women are more prone to have such infections. And if a lady who is not previously had chickenpox, or someone is going to planning for pregnancy, so all these things will be covered by Dr. Jyotsana. And I must tell you that Dr. Jyotsana is youngest among all of us. She is senior resident in Obs and Gynae, and she's going to tell us about chickenpox in pregnancy in a very, I should say, concise manner. So, Jyotsana, over to you. You can start.
Thank you, ma'am. Good afternoon to all my teachers. I'm going to share my views on chickenpox in pregnancy. Now, first of all, we should know what is chickenpox. It is also known as varicella, and it is a highly contagious illness that presents as a itchy rash, and which is followed by a vesicular eruption on the skin. The eruptions basically look like a dewdrop on a rose petal appearance. It spreads by direct contact, that is via respiratory droplets or secretions. The incubation period is around 1 to 3 weeks. Now, after knowing what is chickenpox, what causes chickenpox? It is mainly a DNA virus known as varicella zoster virus, which is a member of herpes virus group of that is SHV3. The primary infection of this virus causes chickenpox, but sometimes it goes latent in the sensory dorsal root ganglion, which may manifest afterwards when the person is immunocompromised. That results in shingles. The humans are the only known reservoir of this virus. For how long is the disease contagious? It is most infectious 48 hours before the rash appears, and it continues to be infectious until the last vesicles crust over. This usually takes around 1 week, around 6 to 10 days from the beginning to end. The point to note here is that the scabs which are formed, they are not infectious. Now, coming to our topic, chickenpox in pregnancy, why are we concerned about this? First of all, the primary varicella zoster virus infection is uncommon in pregnancy. This is because most of us, 90% of the population, are seropositive. That is, they had a history of chickenpox in their childhood. Most of the infections of chickenpox occurs in less than 14 years of age. But the chickenpox in pregnancy, the incidence is around 3 in every 1,000 pregnancies. So the diagnosis of varicella in mother is basically on the clinical findings alone, which manifest as a typical skin eruption. The lesion began as a red papule. The most common site of is face, throat. The distribution of the lesion is centripetal, that is, they grow from center to periphery. Then they progress to clear vesicles, then to cloudy pustules, and finally a dry crusted lesion is there. The systemic manifestations include malaise, fatigue, fever, tachypnea and dyspnea, which may be a symptom of underlying pneumonia, superimposed bacterial infection, headache and photophobia. They may be symptoms of underlying encephalitis. Now, whenever there is a doubt of the diagnosis, we can do a swab. We can take a swab vesicle for varicella zoster virus PCR, or we can do a varicella zoster serology to confirm the diagnosis. Chickenpox in pregnancy has both maternal and fetal risk. The maternal risk is around 5 times. The mother has a 5 times greater morbidity than a non-pregnant patient. So this is the reason why we are so much concerned about this disease in pregnancy. The most common complication is a varicella pneumonia, which is around 20% with higher mortality of 15%. The others include encephalitis, myocarditis, hepatitis, glomerulonephritis, and thrombocytopenia. And the severity of all these complications increases as the gestation period advances. Now, coming to risk to fetus, the risk to fetus depends at what time of gestation period of at what time is the infection occurring in pregnancy. There's an organization called as Organization for Teratology Information Service. It's a European organization which studies the effect of medicines and infections, teratological effect of medicines and infections on fetus. And it is a most reliable organization on evidence-based medicine. According to this OTIS organization, if the infection occurs in first trimester, then the risk to fetus is around 0.5 to 1%. If it occurs within 5 days before delivery and 2 days after delivery, it is around 25 to 30%. And if it occurs between 13 to 20 weeks, the risk is about 2%. Now, if the infection occurs at 13 to 20 weeks, there's a syndrome called as congenital or fetal varicella syndrome. And if the infection occurs near term, then there are chances of neonatal varicella. Now, first of all, we'll study about congenital varicella syndrome. This results from transplacental infection during pregnancy, around 13 to 20 weeks of gestation. And the risk is small, that we have already seen around 2%. The diagnosis of congenital infection is mainly done by ultrasound examination. The features included are intrauterine growth restriction, microcephaly, ventriculomegaly, presence of echogenic foci in the fetal liver, circular scarring, and limb deformity. As we can see in this picture, we can see limb deformity and circular cicatrization around the limb. Then neonatal varicella occurs when maternal infection occurs near term. If infection occurs 1 to 4 weeks before delivery, there are 50% chances of a fetus to get affected, and 23% of these 50% develop clinical varicella. There's a high risk for disseminated varicella. Mortality rates are as high as 30%, but the prognosis is much better if the lesions develop greater than 5 days after delivery, because the antibodies are transmitted across placenta from the mother to the fetus. The manifestation is a disseminated mucocutaneous infection, visceral infection, and pneumonia, more like an adult. Now, prevention of neonatal varicella can be done by isolation of the newborn and treat immediately with varicella zoster immunoglobulin or antiviral therapy. The mother should be made aware of a few things, that is, the potential adverse maternal and fetal sequelae, the risk of transmission to her fetus, and the options which are available for prenatal diagnosis. We should reassure her that the risk of spontaneous miscarriage is not increased if the chickenpox occurs in the first trimester. Now, what should a woman do if she develops a rash in pregnancy? She should report to the doctor immediately, should avoid contact with the susceptible individuals. She should receive oral acyclovir if they come within 24 hours of onset of rash and is more than 20 weeks of pregnancy. Acyclovir therapy in less than 20 weeks of pregnancy can be given because acyclovir is safe. No trials have been seen to see the teratogenic effect of acyclovir on fetus, but it should be done with caution, looking the benefit risk ratio of mother and fetus both. And she should maintain hygiene to prevent secondary bacterial infection. The acyclovir therapy dose is 800 milligram thrice a day for 7 days. Valcyclovir can also be given 1 gram 3 times a day for 5 to 7 days. As I've already said, that there has been no adverse fetal or neonatal effect seen. And the one point to remember is that acyclovir is not recommended for post-exposure prophylaxis. That is, after the rashes appear or after the rashes appear, acyclovir has not been seen to prevent fetal infection. Now, symptomatic treatment include antihistaminic and calamine lotion to stop the itching. Aspirin should be avoided because of risk of Ray's syndrome. Acetaminophen can be given. One point important is to note is that the mother should not scratch the lesion, and the best way to stop scratching is to keep fingers and nail short. Now, when to report to a hospital? A woman should report to a hospital if fever rises above 102 degrees Fahrenheit, lesions become very red, warm, tender, and there is pus leaking out from them. She develops lethargy, she has difficulty in walking, stiff neck, which all shows the features of encephalitis, severe vomiting, and difficulty in breathing and cough, as in case of pneumonia. Now, what are the complications which we are worried about? These are pneumonia, neurological complication, hemorrhagic rash or bleeding, dense rash with mucosal lesions, and in immunosuppressed or women taking corticosteroids for about 3 months, there are indications for hospitalization. Complicated chickenpox in pregnancy, what is seen that there is a high risk of varicella of the newborn with significant mortality and morbidity if the infant is born within 7 days of onset of maternal rash, or a mother develop rash up to 7 days after delivery. In such cases, in complicated cases, IV acyclovir is recommended about 10 to 15 milligram per kg body weight every 8 hourly. Now, if maternal infection occurs at term, then we should possibly delay the delivery by 5 days after the onset of illness. This is because so that the antibodies are transferred to the fetus transplacentally. If delivery occurs within 5 days of infection, then make sure to give varicella zoster immunoglobulin to the neonate. Varicella zoster immunoglobulin does not prevent neonatal infection, but it reduces the mortality rate and morbidity also. Then monitor the baby for the signs of infection for around 14 to 15 days. If neonatal infection occurs, then it should be treated with acyclovir. Now, prenatal diagnosis of varicella zoster is difficult and invasive. The benefit risk ratio is also low. The non-invasive method is with ultrasound, and we should look for the features of cranial calcification, porencephalic cyst, hepatic calcification, echogenic bowel, ascites, hydrops, and polyhydramnios. The invasive method includes amniocentesis, which is not routinely advised because amniocentesis has a poor positive predictive value. That is, if amniocentesis comes out to be positive, that does not mainly indicate that the fetus is going to have a fetal varicella syndrome. Now, timing and mode of delivery should be individualized for every mother. During the viremic period, delivery should not be there because mother has a risk of bleeding, thrombocytopenia, DIC, and hepatitis. And there is also a high risk of neonatal varicella in fetus. Now, if delivery occurs by cesarean section, what is the optimum mode of anesthesia? Epidural is safe because in that dura is not punctured, and any site free of cutaneous lesion should be chosen. In spinal anesthesia, there is always a risk of transmitting virus from skin to central nervous system. And in general anesthesia, it may exacerbate lesion, and also in case of underlying pneumonia, general anesthesia is dangerous. Now, pregnant woman with a history of contact with chickenpox, if she comes to us, the first thing we'll do is to take a definite past history of chickenpox. If she has a definite past history, then reassure her that that her baby is of no risk. But if she is not immune and has a significant contact means that she has the contact with this in the same room for around 15 minutes, or there is a face-to-face contact for around 5 minutes. Then give varicella zoster immunoglobulin as soon as possible. Now, varicella zoster immunoglobulin is best recommended within 96 hours of exposure of a pregnant woman. But if she comes after 96 hours, then it is not that we don't have to give it. We can give it up to 10 days. It is effective when given up to 10 days after contact. A second dose may be required if there is a further exposure, or 3 weeks have elapsed since the last dose, because the half-life of immunoglobulin is around 3 weeks. It is also recommended if it is not possible to obtain an antibody titer within the 96 hours. So it is better to give prophylactic VZ immunoglobulin. Now, what are the indications of varicella zoster immunoglobulin? First of all, it should be given in a susceptible pregnant woman. In newborns, if a newborn is born to a mother who develops a rash between 5 days and before the delivery and 2 days after, then the newborn should be given 125 unit dose of prophylactic varicella zoster immunoglobulin. This is the minimal dose which should be given. It can be given up to the dose is about 125 unit per 10 kg body weight. It is given like that, and a maximum of around 625 unit can be given. Now, in neonates born less than 28 weeks or less than 1000 gram, these are those newborns if they are immunocompromised, and if they are exposed, then regardless of the maternal history, VZIG should be given. Similarly, newborns who require intensive care or who are immunocompromised, they should also be given regardless of the immune status or gestational age. Now, varicella prevention. Adults who have no history of chickenpox or who have never been immunized against the disease, they should receive the vaccine. All non-immune or seronegative women should receive vaccine before pregnancy or even in the postpartum period. And if they are planning for the pregnancy, they should at least avoid pregnancy for 4 weeks, that is 1 month. But suppose if exposure to varicella vaccine occurs in pregnancy, then it is not an indication for termination of pregnancy, because the risk, theoretical risk to the fetus we're seeing very small. Now, vaccination is safe during lactation period, so postpartum vaccination is always advised to the female. Now, the dose of varicella vaccine, 2 doses are given 4 weeks apart. The first is given around 12 to 15 months in baby, and second at 4 to 6 years. 96 to 100% of seroconversion is seen between 4 to 6 weeks post-vaccination, and the antibody titer is more than 90% even after 20 years. Now, summarizing what we have seen in last 15 minutes is whenever there is exposure to varicella in a pregnant woman, we should take the well-documented history of the exposure. If she has a well-documented history, reassure her that neither she nor her baby is at risk. But suppose if there is no documentation of natural infection, then obtain the IgG serology. If it is positive, reassure the patient that there is no risk. But if it is negative, then administer prophylactically varicella zoster immunoglobulin or within 96 hours preferably, or it can be given up to 10 days, or we can give acyclovir or valcyclovir. If mother does not develop infection, it is well and good. But if she develops acute varicella, if it is mild, treat with acyclovir or valcyclovir. But if it is severe, give intravenous acyclovir and then evaluate the baby with ultrasound for signs of infection. Thank you so much.